Good morning. I think we're live. All right, confirmation there from Courtney that everything's working. Hi, everyone. Thanks for joining. We're going to be answering your COVID questions today. Some obviously a really tough time for everyone. Let me just bring up the questions here that Courtney kindly sent me to answer for you guys. Lots of people logging in. This is great. Sorry guys, I'm having some technical issues here with my internet loading. Hope it doesn't have a virus. All right. Let's get going here. Finally. So first question, a very obvious one, a good one to start off with. So what exactly is COVID-19? Well, COVID-19 isn't the virus. COVID-19 is the disease that the coronavirus causes. Coronavirus is the name given to the SARS-CoV-2 virus. That's the formal medical name, and really it's got nothing to do with the flu. It's been compared to the flu, but it's not the flu. It's not an influenza virus that is the same type of virus family that causes the flu, but some of the symptoms initially can be similar. So the symptoms of a COVID-19 infection are fever, a dry cough, shortness of breath, especially on exertion. So if you're doing something and all of a sudden you're a bit short of breath and you kind of think that's weird, then that may be the first symptom that you have. A lot of people have fatigue, poor appetite, headache, and some people also have GI symptoms like diarrhea. Please don't go out and hoard toilet paper. There's really no need. But yes, that can be a symptom. You've got to bear in mind, though, that at least 25% of people who become infected with the coronavirus never develop symptoms. So that's why social distancing is really, really important. 6 feet from anyone when you leave the house. Obviously, inside the house with your loved ones, it's very difficult to stay 6 feet away, and the cat really is out the bag in terms of at home with your loved ones. So there's really no need to social distance from them. Unless, of course, there's been a concern that a family member has been exposed. In that case, please try at all costs, if it's possible, to separate that individual from the rest of the family. A lot has been made of the fever because it's such a common symptom if you have symptoms of COVID-19, but you don't need to have a fever to develop COVID-19 or to have COVID-19. In fact, all of those symptoms I mentioned, they can occur on their own. So I have a very close friend who was recently admitted to hospital for care, and he just felt fatigued for many, many days before the shortness of breath kicked in. So He never actually had a fever at all. So we're hearing more and more of those cases, more and more of those situations. So how is the virus spread? Well, this is first and foremost a respiratory disease. So the virus attacks your lungs first before it attacks anything else. That's how it really tries to get a hold of your body, is through your lungs. So coughing, sneezing, and even people are now talking about just breathing. Anything that releases droplets that are then carried for several feet. Anything that releases droplets into the air can spread the virus. So that's why the social distancing is really being emphasized, because the best way to protect yourself is to stay away from others, at least 6 feet. You can also you can also get the infection through touching someone who's infected, or very close contact. Doesn't have to be a droplet. The way that works is the virus gets on your hand, and then you touch your face. And then if you touch your mouth, your nose, your eyes, that's how the virus then gets into your system, because it was on your hand. So coronavirus can stay alive outside the body for many hours, and depending on the surface, for many days. So metal surfaces in particular can have coronavirus on them. So doorknobs, shopping carts, and the virus can stay on metal. Some studies are saying 3 days. Others have suggested 5 days. When you look at the cruise ship data, there's some evidence that it can last even up to 9 days. That's probably, if that's true, it's probably to do with environmental conditions like sunlight and warmth, heat. We just don't know, quite frankly. But what we do know is the virus survives on metal for at least 3 days. So if you have to go to the grocery store, not only wipe down the cart, but I would actually recommend that you wear gloves. There's been a shift in terms of the recommendations for face masks. Initially, the CDC and the World Health Organization, their stance was that you didn't need to wear a face mask unless you were sick. Reason for that being that face masks really weren't that protective if you weren't sick already, and the reason to wear a mask if you were sick was basically to keep the virus to yourself and to prevent spreading it. But, I'm sure those of you who have been watching the news and the images from around the world, when you look at images from the countries that have dealt with the virus more successfully than the US, places like South Korea, Hong Kong, Singapore, when you see images of the public, everyone's walking around with a mask. So now the sense is that there's something to that. And even though face masks won't protect you 100%, the recommendation now has shifted. And I would say, if you're going out to a store or grocery store, supermarket, whatever, I would say wear a mask of some sort. So if you don't have a mask, wear a bandana over your nose and your mouth. It's better than nothing. And face masks aren't even 100% protective, but they do something. So I do feel very strongly that we have to prioritize the safety of our first-line healthcare workers. A lot of them are dealing with patient after patient after patient who are infected, coughing, sneezing, Our first-line healthcare workers must be prioritized in terms of face masks and other personal protective equipment. But in terms of what our patients do, if you have a mask at home, great. Please don't hoard stuff. If you don't have a mask, it's okay. Just wear something like a bandana. Even that will help. So there's another question, how should individuals protect themselves? Okay, so in addition to what we've just said, think about what you're touching. So hopefully you're all social distancing, you're all staying at home. If you're not, you should be. If really it's the only way to stop the transmission. If you think about people as dominoes, when you line up dominoes and then you flick one and then each domino falls after you flick the first one over, what social distancing does, if you imagine each domino to be a person and the virus spreads from person to person just by being in proximity, being close to each other, that first person who gets infected potentially infects 3 other people. The only way to stop the dominoes from falling is to move a couple of dominoes out of the way so that when the last domino falls, it doesn't touch the next one and doesn't push the next one over. That's how social distancing works. The infection stays in those infected folks, doesn't spread, and eventually it dies out. That individual hopefully gets better, and most people do get better. So 20% of people who get symptoms, the symptoms are mild. Another 20% of folks will have more severe symptoms, but probably won't need to be hospitalized. And really, it's only about 10 to 15% of people who get the infection that will need hospital care. And of those, it's about 5% that will have really severe breathing problems and will potentially need intensive care unit, ventilators, and the rest of it. So when you who is at risk of developing serious symptoms? Okay, great question. So a lot was made of the media that really this was a problem for the elderly and people with other medical problems, and that definitely stands. People who are most at risk are those who have compromised immune systems. So people who are older, especially over 60, people who have other medical problems, diabetes, kidney disease, high blood pressure, any other medical problem that is significant. But also if you're immunocompromised. So obviously cancer patients are very much on that high risk list. Now, if you're a 10-year survivor, you're 10 years out from chemo, your risk is you're not considered immunocompromised anymore, and you're not high risk. But if you've just finished chemotherapy, you're high risk. If you're going through cancer treatment right now, if you have a current cancer diagnosis, you're high risk. So you've got to protect yourself. And you've got to really minimize your contact with the outside world, minimize doctor visits as much as you can. Obviously, that's impossible if you've got cancer treatment still going on and you need to go in to see your oncologist. But if you've finished treatment, you're not getting active treatment right now, don't go for a mammogram, don't go for your ultrasounds. All those things, they can wait. All screening tests now, the American Society of Breast Surgeons really has recommended very strongly that all screening tests, for example, are postponed. So why have hospitals cancelled breast reconstruction? I'm just going to get through this initial list, and then I've got a bunch of other questions coming in that I'll address, so hang tight. So all breast cancer treatment has been really studied. There are a bunch of recommendations now from the American societies, the American College of Surgeons, the American Society of Breast Surgeons, and also the American Society of Plastic Surgeons. So any breast cancer care that doesn't involve surgery is essentially being prioritized. So if there's any possible way you as a breast cancer patient can be treated right now without surgery initially, without it impacting your prognosis, then that's the recommendation. For example, if your cancer can be controlled by hormone therapy or an aromatase inhibitor, or you can have neoadjuvant chemotherapy first before your surgery, all that's going to be basically prioritized. We want to keep people out of hospital as much as possible. The last thing our breast cancer patients need who are immunocompromised is to go into surgery, be exposed to the virus, and then, as I said, this affects your breathing, your lungs, your pulmonary, your respiratory system. The last thing you want to do is go into surgery for a surgery that could have potentially been delayed a little bit, and then you end up on a ventilator because you contracted the virus. So this is, of course, a lot of the conversation, and rightly so, is about preserving resources to get all the COVID-19 infected patients through this and minimize the death rate from that. But please know this decision from our societies in terms of breast cancer care, it's to protect you. So please remember that. Breast reconstruction, as a result, also, if your surgery is not immediately life-saving, it's going to be postponed. And certainly here in Texas, that's the position. In certain situations, in certain parts of the country, very much depends on the geographic situation, how things are, how bad things have gotten. It also depends on your state laws. There have been several state laws that have been passed that prevent certain surgeries. So please talk to your medical team, your surgical team, about your specific situation. But where we are, basically all breast reconstruction is on hold because it's been deemed that it's not immediately life-saving. Obviously, unfortunately, that really does prolong the process for many people. Lots of patients have now been caught in limbo, but you will get through this. You will get your surgery. I don't know when things are going to be back in terms of scheduling. Certainly for us, we're looking at this in 2-week increments moving forward, and it's a very fluid situation. Numbers are changing, the infection numbers are changing, the projections are changing. It's a day-by-day thing. We just have to prioritize everyone's safety. So unfortunately, I can't answer the question as to when people will be rescheduled. All I can say is they'll be rescheduled as soon as it's safe to do so. Just bringing up some more questions here. Okay, can you get the virus again if you've already been diagnosed? So we think that if you've been if you get it once, that you'll be okay for this season. I mentioned at the beginning that coronavirus is an influenza virus. It's not the flu. But in terms of immunity, it probably is quite similar. So when you get the flu, it doesn't mean you can never get the flu again. But it does mean that probably if you do get the flu again, it won't be quite as severe. It is so your immune system does protect you somewhat for the following season. Obviously, the flu shot is a big help. I'm not going to get into the whole pros and cons of vaccination. Personally, everyone in my family will always be vaccinated because vaccines work. But let's not talk about the pros and cons of vaccines in this Facebook Live. Hopefully a vaccine for coronavirus or for COVID-19 will be available soon. When you look at how long it takes to develop a vaccine, and several companies are working on it already, but realistically, it's not going to appear, I don't think, before the beginning of next year at the very earliest. It looks like right now that if you get COVID-19, that you should be okay and you won't get it again, but we don't know for sure. How long can someone be a carrier? I don't know. I don't know the answer to that because without widespread testing, we don't know who is a carrier. So we don't know how long they've been carrying it. If you look at the lifespan of the disease, really, if you get through 2 weeks, which is why for folks who are in quarantine, it's 2 weeks to make sure that they don't develop any symptoms. So we think that after 2 weeks, the virus kind of burns itself out. But we don't know for sure. There have been a small percentage of people who have become infected and ultimately didn't develop symptoms until beyond 2 weeks, but that's only about 1% of people who have been infected as far as we know. Any medicine that we can take to help stop the intensity if we start feeling symptoms but don't know if it's in fact COVID. No treatments really that we know of that have been proven to be effective. Obviously there's a lot of hope being put on hydroxychloroquine, Z-Pak and zinc as a cocktail. The data on that is very poor, to be honest, in terms of vigorous scientific data. It's not strong data. If you develop symptoms, the only thing you can do really, just like if you develop symptoms from the flu again, it's just supportive. It's making sure you stay well hydrated, making sure you're still eating as much as you can. It's supportive measures only, really. Is there a blood test for antibodies to determine if you've already had it? It's coming. It's not here yet, and it's certainly not going to be widely available for a while, but it's coming. And then there's another question. If someone completed radiation treatments 8 years ago and they are 65 and they have a compromised immune system, should they be going to work? So I wrote an article that's published on breastadvocateapp.com. So go to the news section, and there's an article about breast cancer, coronavirus, and what breast cancer patients should know. And there's a whole list of things, precautions, advice. And one of those is, if there's any way you can work from home, do it. Because again, going back to social distancing, we're at the point, and we've been at this point for a while now. This isn't going to go away on its own. It cannot be life as usual. The best thing anyone can do to protect themselves is limit their risk of exposure. So the only way to do that is to stay home. Leave the house only when you absolutely must, and then when you go out, be a minimum of 6 feet away from everyone. So obviously, that means that most people should be staying at home and working from home if that's at all possible. Now, I fully appreciate that unless it's mandated by your individual state, it's very much left up to your employer. But please push it as much as you can to work from home. I was supposed to have prophylactic surgery this year, but it's been postponed. Should I ask my doctor about going on tamoxifen? Yeah, that's a great question, great approach. Anyone who has a high risk gene mutation, anyone who carries a gene mutation like BRCA is obviously the best known, but certainly not the only one. Anyone who's a carrier of a high-risk gene mutation should talk to their physician about steps that they can take that don't involve surgery to see them through until the point where they can get surgery. Please also remember that non-surgical methods of risk reduction, a lot of people choose those off the bat. It's a very, very valid way to go to decrease your risk. Obviously, like, as I mentioned earlier, the screening aspect of it is going to take a hit for the next, I don't know how long, a few months maybe in some places. But you can definitely go on risk-reducing medications like tamoxifen. So that's a great question. So let me see here. Those are the texts I've got. I'm just scrolling down. Here's another quick question. If it does not impact prognosis and local hospital resources allow for a choice between hormone therapy or a mastectomy, is it still preferable to opt for immediate mastectomy with DIEP flap later? Well, if it doesn't impact your prognosis, then you can also look at it the other way and ask, why have the mastectomy if that can be delayed? So from a strictly cosmetic standpoint, immediate reconstruction is going to be better. Some places, you can still have your mastectomy and have a tissue expander placed so that the tissue expander preserves the skin envelope, and you can later have that expander exchanged for your DIEP flap. So in that sense, you do get an extra surgery because the DIEP flap and the mastectomy aren't being performed at the same time, but then the tissue expander is used as a bridge between the two. So whether that's an acceptable way to go or not will depend on where you are and the situation, state, hospital system, but primarily the state laws right now. Let's see here, more questions. Do you all do reconstruction surgery for patients outside of the US? Yeah, absolutely. PRMA, yeah. Not right now, though. So right now, at PRMA, we're really not doing any breast reconstruction, unfortunately, but that's beyond our control. That's what has to happen right now. So we are, the only procedures we're performing are for patients who have recurrent cancer, who need the tumor removed and who need what we call soft tissue coverage. But that's a life-saving procedure. It goes beyond a breast reconstruction. It's more of a wound closure. But we're not performing any breast reconstructions right now at PRMA. We hope to get back as soon as possible, and we certainly will as soon as it's safe. we operate and we see people from all over the country, and people from abroad. We have a lot of international patients. So hopefully we can get back to that. As far as our international folks, obviously the added dimension there will be air travel and when it's safe to do so. But we will always prioritize patient safety. But yes, we very much welcome patients from all over the world. And actually, for anyone who's considering coming, now's a great time to have a telehealth visit with any of our physicians, just so you can get your options. So we definitely welcome that. There's a question here. Once we get back to normal and you are allowed again to do surgery, how long would it take to be scheduled again? Oh, great question. Here, I don't know. Here's what I do know. So right now there are 7 of us in terms of surgeons at PRMA. I'm going to answer this specifically in terms of PRMA because I can't speak to anywhere else in the country or any other countries for that matter. But for us in San Antonio, PRMA specifically, we have 7 surgeons. We're all in touch on a daily basis. Here's what I know. We all feel the same way. We're all very passionate about this. We're on sabbatical right now, essentially. I told my wife that this is it. This is the vacation for the year. So we're all going to be working very hard once the operating rooms are opened up to us again. I promise. And we will get everyone in as soon as we can. Unfortunately, some of you will have to wait a little bit longer than, of course, you want to wait. But we're going to get everyone through as soon as physically possible, I promise. Another question, how would we go about getting a conference with you? Go to our virtual consult page. If you go to our website, prmaenhanced.com, and click on the virtual consult, and it's that simple. So we look forward to hearing from you, Christy. Okay, more questions. This is great, guys. Keep them coming. So what is your advice for staying healthy while patients are waiting for their DIEP flap procedure and sheltering in place? Great question. Nutrition, and exercise. Don't start any bad habits. Don't start smoking. You can still drink. Just, use your judgment. And also, obviously, follow your medical oncologist's guidelines in terms of alcohol, because you may be on some other medications. It depends on what part of your treatment you're in, etc. But nutrition is really important. Just try to eat as healthily as possible. And exercise, aerobic exercise, always improves healing. So try and get some exercise in too. If you're waiting for a DIEP flap specifically, remember what your surgeons told you in terms of where you are with your specific weight. Sometimes losing a significant amount of weight can hurt you in terms of the DIEP flap procedure and how much tissue can be moved and how much tissue there is to work with, or any other flap procedure for that matter. So I wouldn't prioritize weight loss, but I would prioritize healthy living as much as possible. What should individuals do about abdominal incisions that aren't healing properly during this time? Well, it depends on the practice that you're in and your physician and how they want to do it, but I'll tell you how we're doing it. At PRMA, if one of my patients has a wound healing problem, the first thing we're going to do is get on telehealth and then take a look at things and see how things look. Not all healing problems are the same. So if we see that it's just a little bit of superficial scabbing or a little bit of superficial oozing and a little bit of TLC is all the patient needs to do on that incision, then that person isn't going to have to come in and increase their risk of exposure by coming into a medical office. If it's something that looks like needs to be cleaned up, and we need to maybe debride or cut away a little bit of tissue to help things heal, then we'll have you come in. But for us, it's a patient by patient basis. Let me also backtrack a little bit and tell you what we're doing in the office again, or remind folks what we're doing in the office again. In case you do still have to come in for an in-person visit. Let's say you do have a wound healing problem, or let's say we're worried about an infection, or a hematoma, bleeding, or anything that cannot be dealt with over telehealth. We, for many weeks now, have been following the most aggressive approaches in terms of minimizing risk in the office. So please be prepared to see the nurse and the physician with them in masks, gloves. It's not personal, it's for everyone's protection. Everything is cleaned with antiviral detergents between every visit. And people will be staggered. So the only patient who will be in the office when you're there will be you, unless it's impossible to avoid that situation. So that's always going to be the primary goal. Okay? So we're taking this extremely seriously and have done for many, many weeks now. If there's someone else already in the office and you have to wait a little bit for the appointment, then you'll be asked to wait in your car outside, and we will text you or call you, whatever you want, whatever works best for you, when we are ready for you to come in. So we've got this really streamlined now. So just so you know, we take this exceptionally seriously. And we're only going to be bringing you into the office if we absolutely have to. I'm a 5-year survivor with asthma and on tamoxifen. Am I considered high risk? Yes. Anyone with a breathing issue, like asthma, chronic bronchitis, COPD, smokers, vapors, anyone who vapes, you don't have to smoke cigarettes, pot as well. Anything you inhale increases your risk, because it really decreases your capacity to deal with a pulmonary insult. Anything that attacks your lungs is going to have an easier time if your lungs are compromised, because you inhale stuff on a regular basis that is more than just air. So we've seen a lot of younger folks be hospitalized, and we think that some of that is the extent of vaping in that age group. So I'm 2 weeks post-op double mastectomy with deep flap. Because of COVID, will my face after surgery I guess, so you've had your double mastectomy and DIEP flap. Will your second stage be delayed? Yes. All surgeries are off right now. So yes, unfortunately, your revision surgery, in our practice, most people get a stage 2 or a tune-up surgery, a revision surgery. Step 1, the first surgery is about making patients physically whole. The second surgery is about making them look as good as possible, right? So addressing symmetry issues, size discrepancy, contour issues after a mastectomy, maybe some unevenness, scarring. If you've had a DIEP flap, we address the belly scar to kind of smooth things out, smooth out the belly contour, basically make things look as good as possible. That's stage 2. So yes, all stage 2 surgeries are also delayed. Since I was scheduled for this week, I have been following pre-op instructions. Should I continue? That's a good question. Some of them you'll need to, others not so much. So I would say email your nurse. If you're a PRMA patient, please email your nurse and get in touch and go through the list to see which of those you really need to be continuing and which of those you can kind of put on hold for now. Great question. I'm assuming that the length of time for a tissue expander placement is not a problem, but some family are concerned. I've had a tissue expander in place for 2 years and now it's up in the air. Is there a limit on how long a tissue expander can be in place? No. If you're not having any problems, you've got a tissue expander in place, you're not having any issues, you can keep that for as long as you need to. It's not a medical concern. It doesn't impact your health. If you've got no problems with it whatsoever, please rest assured there's no urgency from a medical or health perspective. I know you're probably dying to get it out, but medically speaking, you're fine. Can you demonstrate proper hand washing again? I can try on this little screen. Oh, here you go. Okay, so take off your jewelry. Warm water with soap will do it. Nothing special, right? So quite frankly, if you're in the kitchen and you've got dish detergent, that'll work too, okay? Warm water, and you've got to wash your hands for at least 20 seconds, right? There have been some pretty amusing songs on social media, people picking different songs. Do whatever you need to do that lasts 20 seconds to guide you. But anyway, you get your hands wet with warm water, add the soap or detergent or what have you, lather up, get a nice foam. I would this is kind of like a pseudo, kind of like a surgery scrub light. You know, when we prepare for surgery, well, obviously we do a lot more than this, but this is kind of pseudo hand washing. But so once you've done that for a few seconds, then you focus on every finger and both thumbs, all the way around, all the way around, all the way around. Other thumb, every digit, all the way around. Then you do one hand on top of the other, because you need to do that to really get the web spaces. One hand on top of the other, every web space. Again, the other side. And then once again, finish off. Then get your jewelry. Rinse that. Wash that really, really well. This is metal. Virus can stay on metal for days on end. So wash it really well, put it back on, dry your hands. That's it. 20 seconds minimum, warm water, soap. All right, what's the optimal BMI for a DIEP flap? Good question. So in your 20s, in the optimal is high 20s. So, and I say optimal from a surgeon standpoint. When you get, obviously, so up to 25 is, so the normal BMI is up to 25. As DIEP flap surgeons, we like it when patients are a little bit heavier. It's a little bit easier to get more volume, obviously. I wouldn't encourage gaining weight. I really avoid doing that at all costs, just to make someone a candidate for surgery, you know. Some people are happier at a slightly higher weight, and that's fine. It gets harder to do DIEP flaps when the BMI starts to get down towards 20. Most women can still get a DIEP flap even with a BMI of 20, but a lot of it obviously depends on how you carry the tissue that you do have, where it is on your body. Some ladies with a BMI of 21 have had a couple of kids and they've got a little pooch, as they call it, quite often. I had a lady the other day refer to it as a kangaroo pouch, which I hadn't heard before, but that works too. But anyway, some tissue that they wouldn't mind getting rid of. So if that's over the lower abdomen, we can use it. Now, ultimately, in addition to how you carry your tissue, the other big factor is your breast size and what your expectations of final breast size are. And then also whether you're reconstructing one breast or two. So a lady who's very thin, who needs one breast reconstructed, who wants to keep the other to preserve sensation, or because the risk of the other breast is low, or what have you. So in that situation, we can use all the lower tummy just for the one breast. That's often referred to as a stacked flap. But even ladies having bilateral procedures, so both breasts, can often have DIEP flap surgery when, even though a lot of surgeons will say, oh, you know, you're too thin, you're not a candidate. It really does depend on how you carry your tissue. So even lower BMI patients, low 20s, can still be DIEP flap candidates. We see a lot of people in our practice who have been told elsewhere that they're not candidates for DIEP flap surgery for a variety of reasons. Previous abdominal surgeries, very few prevent DIEP flaps. So certain types of abdominal surgeries, like a tummy tuck, if you've had a previous full tummy tuck, you're not going to be a DIEP flap candidate. If you've had major abdominal reconstruction, you're probably not going to be a DIEP flap. A couple of those we've pulled off too, but it depends. It's very much case by case. So if you really, really feel that the DIEP flap surgery is for you, or you definitely want to look into it some more, and you've been told you're not a good candidate, I really strongly recommend a second opinion. A second opinion can never, ever hurt. Even if it's just to confirm what your first opinion was, at least then you know, okay? So, and please, by all means, hit us up for a second opinion. We're here for you. We see a lot of people, and we talk to a lot of people who want second opinions. So please, virtual consult form, if that's something you feel would be helpful for you. And then the other thing about DIEP flap and BMI is we tend to push the envelope in terms of high BMI, and that's based on work that came out of our practice. That's a study that we did that was led by Dr. Ochoa. We looked at complication rates, and we found that patients with a BMI of up to 40 are candidates for the procedure. Above 40, the complications really kind of start to take an uptick. So the higher the BMI, the line kind of goes like this. So the higher the risk, the higher the BMI, the higher the risk of issues. But when it gets to 40, the line stops being gradual and straight and kind of goes like this. So now again, it depends on how you carry your weight. There are some ladies who have a BMI of less than 40, but the way they carry their weight, their risk will be more like a lady who has a BMI of over 40. So it's very much an individual case-by-case decision, but that's the guide. So we really, really try and get our patients below 40 before deep flap surgery. It's just safer for you guys, okay? What different platforms are we using for telemedicine? And is insurance covering telemedicine? We're using several platforms where we pride ourselves in being very nimble and patient-friendly. So we can do Skype, we can do FaceTime. Those are the two most popular with our patients, and we've been able to do it that way. We obviously don't document anything in those platforms, and everything is documented straight in our EMR. From a HIPAA protection standpoint, but Skype and FaceTime are the two most common platforms that we're using. Insurance is covering it, and last time I saw, please confirm this with your own insurance plan, but last time I saw, the co-pays and deductibles for telemedicine during this time were being waived. So, but please do check with your individual insurance carriers, insurance plans, to make sure that's the case. Is PRMA taking care of billing insurance for telemedicine consultations, or is that the patient's responsibility? No, we'll take care of it. Yeah, so virtual consult, and very easy, very quick. I think that was the last question. Yeah. So I'm going to call it. So thanks very much for tuning in. If you'd like more Facebook Live events to answer questions or on certain topics, please get in touch. Give us some ideas for topics you'd like for us to cover. So got a little bit more time on my hands right now than usual. Yeah, please get in touch. Let us know how we can help in terms of information. Now's a good time to research your options, that's for sure. So please, everyone, take care of yourselves. Stay at